Hello, good evening, everyone. Thank you for joining tonight for our webinar. We just want to send a warm welcome out from ICU Reach. Tonight, or today, depending on where you're from, our webinar is going to be by Dr. Tasbir Islam, and it's about normal saline versus balanced fluids. And we're going to look into what the recent literature says. Dr. Kerala is going to introduce Dr. Islam for us today. So I'll hand it over to Dr. Kerala.
Oh, thank you very much, Grace. Tasbir, it is our pleasure to have you with us here. Dr. Islam is a clinical associate professor at the University of Indiana University Medical School. He's also the medical director of the Division of Pulmonary and Critical Care Medicine in the hospital. He's also the chair of the Planetary Health Academia, and this is how I got to know Tasbir. We worked together on a few courses, including basic and advanced mechanical ventilation, hemodynamics. Dr. Hawa was with us also with the hemodynamic course. And it was really great to meet different people from the Planetary Health Academia. The academia is actually a great organization that offers similar, it has a similar mission to our mission at ICU Reach, where they provide medical education online to the Far East area and mainly in Bangladesh. I think Tasbir today is going to be enlightening us more about a very debatable subject. And I think in terms of fluid use in the ICU, we follow our own local practices rather than evidence. And probably it is about time where we can start following the evidence, because now we have much more towards this subject. And today we will see at the end of the meeting whether we're going to change our practices and be able to move towards one of those fluid types or the other. So Tasbir, I would give you the podium or the mic, and would be very much interested to hear what you're going to say.
Thank you so much. I want to thank Dr. Kerala and Grace, and I also want to thank ICU Reach for inviting me for this to take this session. Today, I'm going to talk about normal saline versus balanced fluid. What does the recent literature say? We all know that the IV fluid is the most common and on many occasions is a life-saving intervention worldwide. So if you walk through ICU or walk through emergency room, you will see over 90% patient is on IV fluid. So over the last, I would say 10, 12 years, there is a concern about the IV fluid, the type of IV fluid we use. Is normal saline is good? Should we use balanced fluid? And that kind of debate is going on. And if you see over the last 10, 12 years, there's a lot of paper came out. So I'm going to highlight the comparison, the study comparison, the normal saline and balanced fluid. And then at the end of the session, we'll find out which is the best for us. So I don't have anything to disclose. So I want to start with the quiz for the audience. So what do you use for fluid resuscitation? Normal saline or balanced fluid? Just want the response from the audience. Can you see the response? 50-50. Very interesting. Okay. Very interesting. Okay. Let's see the next question. I don't know why I cannot. Okay. Okay. Does any of you change your practice based on recent literature? For the audience again. 68% they said they changed their practice recently based on recent literature. Okay, nice. All right, so if you look at the study by Hammond and his group published in 2017, and the study done between 2007 and 2014, if you look at in 2007, many actually use the colloid at that time. Almost you can see more colloid than the crystalloid. But if in 2014, you can see we are using more crystalloid than colloids. Then if you look at the middle graph, that the bar graph, the saline versus balanced fluid, if you look at 2007, we're using more saline, but now in 2014, that is almost 8 years ago, 9 years ago, we are using more and more balanced fluid. And we all know, until now, there's more study came out. So we'll go through all the literature. If you look at the colloid, the choice between albumin, gelatin, or hydroxyethyl starch, surely we all know we are using more and more albumin, that is human albumin solution. So that is the common practice. So you can see from this slide, we're using more and more crystalloid, and we're using more and more balanced fluid. So type of fluid, that is a question, and that is what I'm going to talk about. How do you choose the fluid? So the next slide, the question again for the audience, that is my third question to the audience. Many drugs are incompatible with Plasma-Lyte because of presence of calcium. So for the audience. $45, $55, almost close. Okay, we'll talk about this. All right, so so it is actually false because Plasma-Lyte does not contain calcium, it contains magnesium. The fluid which has calcium, that is LR, or lactated ringer. All right, now let's go through the composition of the crystalloids. So if you look at the plasma, we know we have sodium, potassium, calcium, magnesium, albumin, chloride, all these bicarb. But if you look at the normal saline, it has only sodium and chloride. That's it. It doesn't have any other electrolytes. And importantly, the normal saline has supraphysiologic chloride content, very high chloride, 154. Normal chloride is around 100, 110. So it's very high chloride content. If you look at the ringer lactate, that is the Sydney Ringer, is a British physiologist, actually invented that fluid in 1882, adding sodium, chloride, and potassium, and calcium, and they found is try to make it more closer to plasma. And then in 1932, the American pediatrician Alexis Hartman's actually come up with the plan that causing a lot of acidosis. So let's see whether we can add something to make the pH close to normal. So then he added sodium lactate to ringer solution. That is 1932. Interestingly, if you practice in UK or Ireland, they call it Hartman solution, but they want to honor the American physicians Alexis Hartman. But in US, actually, we don't call Hartman's, we call it Ringer's lactate, because American wants to honor the Sydney Ringer. So it's a reciprocal, see, we are respecting each other. So anyway, so that is the sodium lactate added to the Ringer solution. And so it has got sodium, lower number, not a 154, is 130. We have chloride, much lower content, 109. Then we have lactate, sodium lactate. And then we have the potassium in it. And the Plasma-Lyte, that is actually came in market in 1982 by Baxter. And it is actually, instead of calcium, they're using magnesium. So if you look at the head-to-head comparison between lactated ringer and Plasma-Lyte, there's a couple of differences. One is they use sodium lactate as a buffer in lactated ringer, but in Plasma-Lyte, they use sodium gluconate or sodium acetate. Another difference is lactate has, ringer's lactate has calcium, but Plasma-Lyte has magnesium. And if you look at the pH and osmolality, Plasma-Lyte is more closer to plasma than ringer lactate, slightly better in terms of osmolality and the pH, more closer to plasma. So, and Plasma-Lyte is also a little expensive. And also it found that, because it has got sodium gluconate and sodium acetate both, they're higher risk of make the blood alkalosis. So question number 4 for the audience. How much of an isotonic crystalloid solution remains in the intravascular system when you give a fluid bolus? 80%, 60%, 40%, or 20% for the audience? So mostly they said 40%. Some of them says 20 and 40. Okay, nobody says 80%. See, so actually 20% stays in the intravascular system. So, and why it is very important? Because when you do the resuscitation, and when you talk about that, hyperkalemia can happen, or pH can be, can go down, or chloride level can go up. That only 20% what you're giving, making the difference. And also for the resuscitation, that the amount of fluid stays in the intravascular space has effect on the hemodynamics, not the rest 80%. So that is, we talked about that 20% stays in the intravascular system, 80% actually goes in interstitial space. And if you use the hypotonic solution like D5, only 8 to 10% stays in the intravascular system. That's why we don't use D5 water or D5 half normal for resuscitation. So question number 5, normal saline is an unbalanced but buffered crystalloids. True or false for the audience? True 36, false 64. Actually, it is false. And I'll tell you, there's two terms I used here. One is balanced, one is buffer. So we need to know what does it mean. Balanced fluid means when the fluid is chemical composition is closer to plasma. So I take sodium, potassium, chloride, bicarb, these are all close to the plasma level. Then we call it balanced fluid. Buffered is the solution which tries to keep the pH close to normal. So that's why we add sodium lactate in ringer solution, or we add sodium gluconate or sodium acetate to Plasma-Lyte to produce bicarb by the liver, so to convert those to the bicarb, so that keep the pH normal. So you may ask me a question: why do you use sodium lactate or sodium gluconate or sodium acetate? Why don't you add bicarb straight to the solution? So the reason we cannot use bicarb in the solution, because bicarb is very unstable solution in a plastic bag. The gas permeable bag we use normally for the fluid, the bicarb is very unstable. That's why we can't use bicarb straight. We use either lactate or acetate or gluconate, and that actually converted to a bicarb by the liver. So quiz number 6. Normal saline causes metabolic acidosis because of dilution of bicarbonate. Is it true or false for the audience? Right, okay, majority says is false. So, and that is false, because in the past, when we are using that normal saline since 1830, 32, that's kind of that time during the cholera endemic in UK, and they found a lot of patients actually is now had metabolic acidosis because of normal saline, and they thought it's dilutional. They thought maybe we dilute the bicarb, that's why patient is more acidotic. We find out actually that's not the case in late 70s and 80s, when we found actually it's not the dilutional effect, it is due to high chloride content. We call it hyperchloremic metabolic acidosis. It's due to high chloride. So I call it abnormal saline because it has got too much of chloride and also high sodium. And that actually causes hyperchloremic metabolic acidosis. And typically we see that, acidosis or the hyperchloremic acidosis when you give large volume, like more than 3 or 4 liters, then you start seeing that hyperchloremic acidosis. We know certain patients like shock patients, septic shock, or DKA patient, or burn patient, acute pancreatitis, actually they need a lot of fluid, not like 2-3 liters, they need a lot of fluid. So they are actually higher risk when you give a lot of fluid to, if you give normal saline, the hyperchloremic acidosis. And is it a problem? Is hyperchloremia is a problem? It is a problem because it can cause renal vasoconstriction, that can decrease the GFR, that also can suppress the renin activity. So it can cause AKI, or acute kidney injury. Also, because acidosis, we all know it causes vasodilatation and myocardial-depressant. So it actually makes the shock worse by myocardial-depressant and also causing vasodilatation. So it may cause problems. So now quiz number 7 for the audience. 48 years old, male patient admitted with history of profound weakness, dizziness, fever, chills, cough with yellowish phlegm for 2 to 3 days. He was found to be tachycardic, tachypneic, and hypotensive. Lab showed WBC count is 26.6, lactate 4.4, creatinine 2.2, potassium is little high 5.4, and chest X-ray showed extensive right-sided infiltrate of pneumonia, meaning patient has significant sepsis from the pneumonia. So LR, which is a balanced fluid, and it also has potassium in it. So we thought, the physician thought should not be used because it can make the hyperkalemia worse. It may cause lactic acidosis worse. True or false for the audience? In other words, they should not be used because of potassium and sodium lactate. Okay, 85% says false. And actually it is false. You have to remember that, and I'll go through the next slide, that we don't give lactic acid through the ringer lactate. So it's not lactic acid. We give actually sodium lactate. So it is different. Sodium lactate convert to a bicarb in the liver. So you need a good liver, that's for sure, but it's not lactic acid. Number two, the potassium part. I know the LR has potassium in it. So our patient has already 5.4 the potassium. So you can say maybe it may cause more hyperkalemia. Okay, I'll go through the math. Before I go through the math, I'll show you one thing. That is, what's the argument for using saline and why they like the merit? So everybody say, oh, normal saline is cheaper. We learned when I was in training, everybody said normal saline. My boss says, my mentor says normal saline. That's the way we learned, but that's not the case. Because number one, normal saline is cheaper, but LR is also cheaper. Number two is the lactated ringer is not safe with hyperkalemia. That is not true because I'll show you the next slide, but this slide, the study shows in salted and SMART trial. I'll go to the trial.
Did we lose him?
Yeah, we did. I'll communicate with him. Yeah, I think he's back. Yeah, yes, you're back. We lost you. Unmute yourself, Casper.
Can you hear me now?
Yes, we hear you. Share your screen.
Yeah, I have to do it again. 1 second.
You're muted, Dr. Carol.
Looks like we have very educated audience.
Can you see my slide? No.
Not yet.
Not yet. Okay. Let me share the screen again. Okay. Can you see it now?
Yes. Yes,
Okay.
It's coming. Yes, we see it.
Okay.
Thank you.
So I think I'm on this slide. So basically, normal saline is not cheaper. It's cheap, but LR is also cheap. LR does not cause hyperkalemia. Rather, normal saline causes more hyperkalemia by making hyperchloremic acidosis. Ringer lactate does not cause lactic acidosis because it does not have lactic acid. It has sodium acetate. There's another question comes, and in my previous slide, I showed that many drugs or blood is incompatible with Plasma-Lyte, but it's not Plasma-Lyte, it is ringer lactate because of the calcium. But remember that if you use different channel to different line, you can give the blood and the LR same time, as long as you use the different channel. And number two is for the drug medication, such as ceftriaxone, ciprofloxacin, Ativan, the lorazepam, propofol, ketamine. You can give, there's some interaction, but as long as you use a different channel, then you're fine. You don't need to worry about it. Except someone is younger than 28 days. We're talking about really neonates. And younger than 28 days, in that case, you cannot give ceftriaxone, even with a different channel. So that is the only thing to in mind. Otherwise, as long as you use different channel, that should not be a problem. So now coming to that point, why the LR does not cause hyperkalemia. So I'll give you the scenario. So LR has 1 liter of LR has 4 milliequivalent of potassium. So we know we have intracellular and extracellular. So we know that we have roughly 14 liter of fluid in the extracellular space, that is plasma and interstitial space. So now, if the patient's potassium is 6, say patient's hyperkalemic already, and blood test shows the potassium is 6, so that means this 1 liter has potassium of 6, patient has total of 14 liter in extracellular space, that means patient has 84 milliequivalent. So now, total. Now we give another liter of LR, which has got 4 milliequivalent. So you make the potassium now from 84 to 88, but the volume gone up from 14 to say 15 liter. So what does it mean? If you divide that, now actually patient's potassium is 5.9 milliequivalent per liter with 88 milliequivalent in 15 liters. So actually it does not cause hyperkalemia. And also I say normal saline is more prone to cause hyperkalemia by causing hyperchloremic metabolic acidosis. So as a salted and SMART trial, it shows actually that, it does not, if you look at this graph, shows the normal saline and LR or balanced fluid, no change in potassium, all the same. So it's a myth. Now coming to the latest studies. So as I say, over the last 10, 12 years, we have few study came out, a lot of study came out, but I just talk about few important or landmark studies. So let's do one trial, that is the earliest trial in 2012, chloride trial, that is published in JAMA in 2012. And they actually look at chloride restrictive versus chloride liberal. And what they found is that we know the chloride restrictive means balanced fluid, chloride liberal means normal saline. And what they found is incidence of acute kidney injury is higher and incidence of or the use of renal replacement therapy is higher with normal saline. But there's no other benefit like hospital mortality or hospital or ICU length of stay. But there is a clear higher incidence of acute kidney injury. So now there is a study came out. So all the study, I'll just talk about few of them. So first is SPLIT trial. SPLIT trial is a study in New Zealand done in 4 ICU. So it's a kind of multi-center trial, you can call it, over 2,000 patients. And they use Plasma-Lyte here. They didn't use LR. So Plasma-Lyte 148 to comparing with normal saline. So what they found is that there's no difference in terms of mortality, in terms of acute kidney injury, there's no difference. So problem now with this, that if you look at the patient population, 70% are surgical patients. That means they're all mostly elective surgery, and mostly actually they are all cardiovascular patient, cardiac surgery, post-cardiac. Only 4% are septic patients. So actually it's not more surgical ICU rather than medical ICU. So you don't see any much difference. And number two is 90% of the patient in SPLIT study got some kind of fluid before enrollment. They already got some fluid, then they're enrolled in the study. So that is a downside. Now coming to the study, SALT-8 trial. That is US trial. Is a single center that is done in Vanderbilt in Tennessee, over 13,000 patients, and and what they found, and they use ALR and Plasma-Lyte both, and what they found that there is no difference in terms of mortality, but there is higher incidence of acute kidney injury. So but the problem is now that this is mostly ED patient and inpatient, and also there is only 18% of surgical patient. And a SMART trial, the problem now is, the only downside is they give only 1 liter of fluid. If you look at the median fluid volume, it's only liter kind of thing. So it's not like massive fluid the patient received. So, but it shows clearly the incidence higher, the kidney injury is higher in normal saline group. Looking at the SMART trial, that is also a US trial, and it is a single center, that is a downside. And they have only 8% surgical patient, and there's almost 15% septic patient, but mostly medical ICU patient. And what they use ALR and Plasma-Lyte both, and they also showed the higher incidence of AKI in normal saline group, but there's no difference in mortality. But again, they did not get much fluid in there. So almost around 2 liters. Now the BASICS trial, that is the trial just came out in 2021. This is multi-center trial in Brazil. And what they found is there's no difference in mortality. There's no difference in ICU length of stay or acute kidney injury. So that means they said both the same. So there's no difference. But if you look at it, they use Plasma-Lyte 148 here. But the downside is 60% of the population, the sample, are surgical patients. And 40% of the patient actually not hypotensive. They're not in shock. So that is so 60% of surgical patients and 40% patients are not in shock. And they use kind of decent amount, but not 4 liters, 5 liters, only 3.5 liters fluid over 7 days. So it's not massive fluid they receive. But again, the study shows no difference. Now coming to the PLUS trial that is done in Australia and New Zealand, is the 553 ICU, is the multi-center trial. What they found again, that there's no much difference between these two, the balanced fluid or the normal saline. Remember here they use Plasma-Lyte as a balanced fluid. But here almost 45-50% patients are surgical patients. That is number one. And number two is 63% of the balanced fluid group, as opposed to 3.5% of the saline group, received alternate fluid. So there's some issues of the contamination. 63% of the balanced fluid groups received some other kind of fluid, as opposed to only 3.5% of the patient with normal saline got different kind of fluid. So there is surely a concern about the contamination, but again, it showed no difference. So we found some of the study shows balanced fluid is better. Some of the study shows there's no difference. Some of the study shows there's some mortality benefit, but some of the study shows there's increased incidence of AKI in normal saline group. So now there's a meta-analysis published in New England Journal in 2022, that is in January 2022. They look at 13 trials involving over 35,000 patients. And what they found is, I just go quick, 14% reduction to 1%, 14% reduction to 1% relative increased risk in death in sepsis. So the conclusion was probably the balanced fluid is better and has some mortality benefit, especially in sepsis patient. But remember, they said this is not a fluid of choice in traumatic brain injury. So should not use in traumatic brain injury. So in meta-analysis published in New England Journal, they said, looking at 13 trials, they said probably balanced fluid is better than the normal saline, especially in sepsis. So now go back to the basic trial. So basic trial, we say that is almost 11,000 population. This is a big study. Excuse me. And it shows there's no difference. So they did a subgroup analysis looking at how many of them are septic patients. They found out of 11,000, almost 2,000 patients were actually sepsis. And that septic patient, actually there is a mortality benefit. So it's very important. The septic patient, if you look at the mortality at 90 days, 46.7 versus 49%. So there it shows even the basic trial overall shows no difference, but in septic patient, they say balanced fluid is better and has some mortality benefit. If you look at the SMART trial, the trial we talked about is a single center trial in US involving almost 15,000 patients in Tennessee. What they found is very important message this slide is giving to us. If you start balanced fluid from ED, emergency room, and continue in ICU, then you will see the benefit. But if you give normal saline in ED, then change to balanced fluid in ICU, probably you won't see the benefit. So it's very important to start balanced fluid early. That is important message. So that's why I always go down and talk to the emergency room. Listen, start balanced fluid. So then you will see the difference. So I'll go through a few slides like, DKA patient, pancreatitis patient, because with those patients need a lot of fluid. So if you look at the SMART trial and SALT-8 trial, and they did the subgroup analysis in DKA patient. So what they found actually, DKA resolution much faster, 13 versus 16.9 hours. Insulin discontinuation rate is much faster in balanced fluid, 9.8 hours versus 13.4 hours. And there is a few patient actually has issues with the potassium level. So in other words, that SALT-8 and SMART trial, looking at the patient with DKA, also found balanced fluid is better than normal saline. But there's a few study done, and I just showing a couple of 2 or 3 studies. It also shows if you use balanced fluid, has much faster resolution of DKA, much faster, you can take off the insulin, and much faster to discharge the patient. So if you look at the study published in Critical Care 2022, you can see the study, they compare, and there's a big difference. There's another study shows the same. The message is the same. So even in DKA patient, balanced fluid is better than normal saline. So now coming to the patient with acute pancreatitis. So they call normal saline not only cause hyperchloremic metabolic acidosis and is an unbalanced fluid, also they think normal saline can be inflammatory. So they look at the patient with acute pancreatitis, there's a LR versus saline, and they actually saw at 48 hours and 72 hours, the CRP level higher, significantly higher in saline group than the LR group. So then another study that's published in 2011 by Dr. Wu and his groups, what they found, not only the CRP gone up, also the SIRS score gone up with the normal saline group. So they thought, why LR? How come the LR can be, cause less, CRP level and also cause less SIRS? They actually think, and that they find, they look at the study, they look at the effect of Ringer's solution. Remember that Ringer's solution, which does not have sodium lactate, and then lactated Ringer. Actually, Ringer's solution performed the same as normal saline. That means they're thinking the sodium acetate is anti-inflammatory, directly anti-inflammatory, and lower the CRP and lower the SIRS. So it's very important, even in acute pancreatitis patient who needs large volume of fluid, also benefit from the balanced fluid. All the study, and just not going through, either shows a mortality benefit or shows less kidney injury. There's no study in my research shows that other way, the normal saline is better than the balanced fluid. I didn't see any study. So, but important to remember, there's certain condition you should not use LR. One is frank liver failure. It's not like the cirrhotic liver or hepatitis. Somebody is in frank liver failure, he should not use LR. He should not use LR in elevated intracranial pressure or traumatic brain injury. He should not use LR in somebody who has hypercalcemia or hyponatremia. And there's another condition, he should not use LR. Somebody has metformin-induced lactic acidosis, because LR actually increases the permeability of the metformin to the cell and cause more cell damage. So that's why it's better not to use LR in those conditions. So there's another way to look at, okay, balance versus normal, but there's another way to look at is, should we, such as, if we look at the septic sepsis guideline in the past, in 2008 and before, they said keep the hemoglobin more than 10. But now, actually, we keep it 7 is fine, 7 or more. So that is gone, the blood transfusion thing. Hydroxyethyl starch, we know that is poison. We don't use it anymore. Now I'm hoping after my presentation and the study study recently showed normal saline should not be used. So we left with two choices: balanced crystalloids, or maybe you can use the pH-guided treatment. What does it mean is so if a patient is already alkalotic for some reason, maybe you can argue you can use normal saline at that time because it can cause acidosis and bring the pH to normal. But somebody has normal pH or low pH, I think you should use balanced fluid. Quiz number 8 to the audience. Latest Surviving Sepsis campaign guidelines in 2021 suggest using which of the following fluid for resuscitation? Is it balanced fluid or normal saline? Balance, 100%. I love it. Yeah, so that is the Surviving Sepsis campaign guidelines in 2021 says use balanced fluid, not normal saline. So I just go through a couple of slides, maybe 3 or 4 slides about the colloid versus crystalloid. So we all know the colloid is expensive, but it has got higher intravascular half-life. So we all know crystalloid, as I said in earlier slide, if you give a bolus of crystalloid, only 20% stays in the intravascular space, as opposed to almost 100% stays in the intravascular space first 3 to 6 hours if you give colloid, but it's expensive. So if you look at the SAFE study that is published in the New England Journal in 2004, and the study was done in Australia and New Zealand involving almost 7,000 population, and it actually shows no difference. There's no difference between albumin and saline in terms of mortality and length of stay. But if you look at the subgroup analysis, just looking at the septic patient, actually they found that albumins may be better. If you look at the traumatic brain injury patient, they say it's make the things worse. In other words, colloid should not be used in traumatic brain injury, but they said probably slightly better over crystalloid, but it's very expensive. Crystal trial that is published in JAMA in 2013, looking at the colloid versus crystalloid. And what they found actually at 28 days, there is no difference in mortality, 28 days. But at 90-day mortality, colloid may be slightly better than the crystalloid. But remember that that trial, the crystal trial, they did with hypovolemic shock for any cause, like traumatic brain injury, could be due to hypovolemia, could be due to the septic shock. So in overall, they said not much difference, put it this way. Albios trial,
Looks like we lost him again.
Where is he presenting from?
In West Lafayette, Indiana.
Mm.
Till we get him, Grace, there's a final question I placed. If you can actually launch this, and let's see, elicit some responses from the audience. No, not this one. Let's put it down. It's called final. Do you see it? Okay. So in your next ICU patient with sepsis, which fluid will you use? Is it balanced fluid or normal saline? So Tasber, we just put a final question because we
sure, yeah, I love it.
Actually,
yep.
Yeah. So let's see. Well, you're winning, Tasber. It's already. It's showing that 100% of our audience is leaning towards using balanced fluids in ICU patients.
Right.
So go on, Tasber.
Yeah, I have a couple of slides. The Albios trial, there's an Italian study. They look at the normal saline, the crystalloid versus albumin, keep the albumin more than 3. And actually, they found there's not much difference. If you look at the mortality, if you look at the ICU length of stay, in a ventilated day, there's no difference. But surely less time on vasopressors, less fluid balance, less what they call that one, that amount of fluid you give to the patient. So in other words, small volume resuscitation. So you need less fluid to resuscitate the patient, but there's surely no mortality benefit overall. But if you look at subgroup analysis, look at the septic patient, there is a mortality benefit from the albumin. So that is a SWIPE trial that is showed, to keep, it's done on 300 patients or 321 patients. And what they found, okay, why didn't you approach small volume resuscitation? Meaning, try to give, we all know too much fluid is not good. It can cause ARDS, and it can cause the wet lung. It can cause swollen kidney, then problem with the kidney injury. It can cause the swollen gut, then it can cause, the problem with absorption, or it can cause CHF, or pulmonary edema. So let's try small volume resuscitation. That is the purpose of doing SWIPE trial, giving 2 different concentration of albumin, 20% versus 4 to 5% of albumin. Actually, there's no difference. Surely 20% group required less volume, but there's no as such any benefit. but it can give less volume. In other words, if you're really concerned about any patient, such as 10% EF, patient that's on dialysis and missed 3 dialysis for the last 3 dialysis, patient missed it, and patient EF is 20% or 10%, you're really worried to give large volume, he can think of colloid at that time. Or he already gives a lot of fluid. Still patient required large volume. Then he can decide, okay, I give enough crystalloid, probably I can give now colloid to give less volume and see the hemodynamic benefit. So as I said, all the study, Albios, SAFE, EOS, all actually shows no benefit if you colloid and crystalloid, no difference. But if you look at the patient with sepsis, there is a benefit from colloid, but it's very expensive. Remember, this very expensive. So that's why we don't use albumin. We use crystalloid as a fluid of choice initially for resuscitation, as a resuscitation fluid. Question number 9, and that is the last question for the audience. 53 years old, female patient is brought by EMS to emergency room following motor vehicle accident. She was intubated by EMS, emergency medical service, at the scene of accident. She is unresponsive, hypotensive, and suspect a significant traumatic brain injury. Which of the following should be used as initial resuscitation fluid? Is it balanced fluid, normal saline, or colloids? Somebody with traumatic brain injury for the audience. All right. What is my question? So 71% use normal saline, but 30% almost using balanced fluid. Nobody is going to use colloid. That's good. Don't use colloid, but don't use balanced fluid as well, because we all know. So we want to keep the sodium up in traumatic brain injury in order to decrease the ICP. So, and your goal is to keep the sodium between 145 to 155. So it's very important in this condition, somebody has traumatic brain injury, or someone has large vomiting and losing a lot of, bicarb. In that case, hydrogen ion. So in that case, you can use normal saline. Otherwise, you should not use normal saline. So please, there's a take-home message for you. In traumatic brain injury, don't use balanced fluid. In traumatic brain injury, don't use colloid. It has to be either normal saline or hypertonic saline. So, role of colloids. So currently, the indication of albumin is management of spontaneous bacterial peritonitis. We use that day 1 and day 3. They say give albumin day 1 and day 3. Then you use in hepatorenal syndrome. You use when you do large volume paracentesis, more than 5 or 6 liters, more than 4 or 5 liters of fluid here, taking out. In that case, give albumin. We use routinely in plasmapheresis or plasma exchange. We use post-heart, lung, and liver transplant, after cardiac surgery and major hepatic resection. In those conditions, you use albumin is a fluid of choice. Otherwise, it should be the crystalloid. Though we know in septic patient, colloid is slightly has better mortality benefit than the crystalloid, but it's very expensive. Hydroxyethyl starch is a poison. It should not be used. So in conclusion, we should use balanced fluid, not normal saline, for the resuscitation. And we all know it has clear mortality benefit based on some studies, but some of the studies shows both the same, but remember, no study shows that normal saline is better than balanced fluid. LR is safe. It can be used safely in hyperkalemia. It does not elevate the lactate level. It is incompatible with blood and drugs. So as long as they use different channel, different IV line, should be okay. It's not an issue. Normal saline can be harmful because it's a hypertonic and acidotic, because sodium content is high, and it can cause hyperchloremic acidosis, hyperkalemia, worsening shock by vasodilatation and myocardial depression, AKI, and it also causes systemic inflammation, but can be considered, and it should be considered in traumatic brain injury. Someone has prolonged vomiting and has significant loss of gastric juice. In hyponatremia and hypochloremia, in those patients, he can use normal saline. I think I'm done. Thank you so much for having me. I really enjoyed thoroughly. I'm very impressed with the answer from the audience. Thank you.
Thank you so much for your excellent lecture. I think we'll all have learned quite a lot from that today. We've now got a panel, so I'll just introduce some of the members of the panel as well. So we've got Dr. Kerala, which most of you will know because he's on most of our talks nearly every time. We've also got Dr. Abushala from the University of Alabama. We've got Dr. Dahan, but I think he's disappeared for now. Perhaps he'll be joining us, and he's from Duke University. And then, of course, back to Dr. Kerala, and he's from the University of North Dakota. So a few questions to start. If you have any more, there's a question and answer section at the bottom. You can type them in and I'll be able to read them out. Or if you want to talk, you can raise your hand and then we can unmute you and you can talk directly to have your question answered. So firstly, one of the questions that's been asked, and I think it was covered in the last slide, but what is the choice of fluid in sepsis with patients with hypochloremia?
This question for me?
It's for you,
the
or
panelists?
it can be for whoever wants to answer.
If someone has significant hypochloremia or hyponatremia, probably I will use normal saline, but otherwise the balanced fluid is the way to go.
Okay, perfect. In traumatic brain injury with hyponatremia, say for example a sodium of around 120 millimoles per litre, what should the target of sodium be during the resuscitation?
So as I said, any patient with traumatic brain injury, we want to keep the sodium 145 to 155. But again, sodium is 120. You don't want to cut it too quick. You don't want to bring the sodium from 120 to 145 in 1 hour, right? So that is a very difficult situation. In that case, probably you have to use the mannitol and bring the sodium slowly up. But probably you have to use mannitol as the osmotic agent at that time. So what, Dr. Kerala, what do you think?
I would agree with you, Tasber. Certainly, you would not go up on the sodium very rapidly in those kind of situations.
Perfect, thank you. That is a difficult situation, I'm sure, to manage. What about DKA? Any difference between normal saline and balanced fluid? Again, I think this was answered just before, but if you don't mind giving us a recap.
Sure. Actually, now at the moment, I have 3 DKA patients in ICU, one with pH 6.7, one has pH with 6.8, other one is not bad, 7.1. So I have 3 DKA patients at the moment. We're using balanced fluid. As I said, the study showed, even looking at the subgroup analysis of the SALTED and SMART trial and look at the other studies, it shows the resolution of DKA much faster with the balanced fluid. Number one. Number two, the insulin discontinuation is faster in a balanced fluid. And we all know normal saline, patient already in acidosis, DKA, diabetic kid acidosis. Now we all know the normal saline can cause hyperchloremic as metabolic acidosis. So now we are using more and more balanced fluid in treating DKA patients.
Great. Just a question from personal experience. Do you find that it has an issue with getting enough potassium into the patients whenever you're giving a lot of insulin, which is bringing the potassium down? Do you feel like giving balanced fluids is enough potassium?
Yeah, balance, but that's the thing that, if you look at the DKA protocol, so whenever the person's potassium is less than 5.3, we start replacing it. So now look at that. If they have a tendency when patients DKA have a hyperkalemia, now you're treating with the insulin, they start dropping their potassium level, right? So, and if you treat with normal saline, they will drop more because the acidosis thing. So if you give LR that has some potassium in it, minimal, 4 milliequivalent only, but on the top that you want to replace that one. So in other words, normal saline has higher risk of hyperkalemia, that's for sure, but also can make hypokalemia by making, not hyperkalemia. And LR has some potassium because when you are treating, now you're pushing the potassium inside the cell, patient become hypokalemic, right? So in that case, you have to replace no matter what, if you give LR or normal saline. But because LR causes less acidosis, it's better on the pH or acid-base balance.
Perfect.
Dr. Cholera, you want to add anything?
We started thinking about using LR in our DKA patients based on those recent studies, actually. I think it makes a lot of sense to use LR rather than normal saline.
I'm not sure about within your hospitals, but we can add the potassium to the bags of normal saline, but we're not allowed to add potassium to the bags of Ringer's lactate or Hartmann's. So usually we would treat with potassium, 40 millimoles potassium in a bag of saline versus using the Hartmann's. So it's difficult because they won't let us add additional. So I think it would be trying to change the mindset within our departments to using just a balanced fluid would be difficult, but it is interesting to see that it's all still work.
And that's
the
why
the patient I have now, actually, patient is getting LR with 220 kcal potassium in it. So,
a lot of this is driven by local hospital policies, actually, rather than by evidence. And you give me an example of that, Grace. Thank you.
Yeah, definitely. But it takes time for things to change in any hospital. I'll move on to the next question. Does higher osmolality in normal saline provide any benefit over lactate or Ringer's lactate?
Say that again. Sorry, I missed it.
Sorry, does higher osmolality in normal saline provide any benefit over LR?
Yeah, so if you look at the osmolality of the normal saline is 308 kind of range. And if you look at the osmolality of the LR is around 273 to 75. So it's more closer. Normal plasma osmolality is 280 to 90. So that's why it is slightly hypertonic. They call it isotonic. Actually, it's not isotonic, it's hypertonic. And number two is it has got a lot of chloride in it. So basically, that's why we try to use the solution or IV fluid, which is more closer to plasma. Yeah, you can argue the LR has low pH, maybe slightly hypotonic. I agree. Plasma-Lyte is more closer to plasma in terms of osmolality and pH, but more expensive. So in fluid resuscitation, if you look at, I will use more, which is closer to plasma rather than higher osmolality fluids. So.
Go ahead. I think there's another question, and then I have a comment.
So another question: resuscitation fluid of choice in acute liver failure.
Okay, so as I said, if it's acute liver failure or frank liver failure, not cirrhosis of liver, not hepatitis, in that case, it should not use LR. or you should not use Plasma-Lyte because they all go to the liver to convert to a bicurve. So if the liver is diseased, like frank liver failure, you should use normal saline at that time. So only use, there's the indication, there's only, I think, significant contraindication of balanced fluid. Somebody has frank or fulminant hepatic failure. Again, I want to make a stress on it. Is not if somebody has cirrhotic liver or patient has, that hepatitis, he can use ALR safely.
Perfect. And then there's the final question. Is there any role for hypertonic saline in fluid resuscitation?
I never used hypertonic saline for sepsis or shock patient. I use hypertonic lot for traumatic brain injury or raised ICP. So I don't see any benefit using 3% for the shock patient. Dr. Kerala, do you have any comments on that?
Never actually. I never use 3% for that purpose. We just rely on the balanced or normal saline fluid, but we're changing our practice also. I wanted to say, though, that the evidence is not so concrete where balanced fluid is more beneficial than normal saline. However, we see evidence that normal saline is associated with higher risk of acute kidney injury. And the meta-analysis that you presented very nicely, Taza, by the way, was great presentation. I like it in a way that you gave all this evidence and then you selected those subgroup of patients where you certainly are not eligible to use the balanced fluid. I want to repeat that for the audience. I put it down here because it's so important that balanced fluid should not be used in patients with TBI, traumatic brain injury, in patients with liver failure, in patients with hypercalcemia, patient with hyponatremia, and metformin-induced metabolic acidosis. I just wanted to say that the meta-analysis that included 13 different trials and presented in the New England Journal of Medicine evidence edition of it, it's based on the Bayesian analysis. And the Bayesian analysis would give you the likelihood or the probability of benefit. And within this, I think we lost Dasber again, but within this analysis, it gave us that the chance of harm is more with normal saline than what it is in balanced fluid. So if I have this evidence in my hands, even though it is not that strong, and I know that for sure that it is more likely to hurt my patients with normal saline, why should I use it? So I think this is moving the ICU practice towards using more balanced fluid compared to normal saline in general. If we get more evidence to support that, would be great. I believe that there are certain type of certain subgroup of patients who might benefit from balanced fluid more. The pancreatitis patients, the septic patients. I'm not sure about the ARDS patients too. It hasn't been studied very well. And as you see, those studies included all type of patients together. And in fact, the heterogeneity of those studies making it difficult to make a clear interpretation of these results. So, Nabil, are you still with us? Nabil got busy, actually sent me a message, but I thought if he's still with us, he can actually give his point of views. That was a great presentation. I really enjoyed it, Tasber. I think you made it so simple, easy. The involvement of, I'm impressed with the audience that actually gave the answers towards what's in the literature. And that tells me that people are actually following the literature and updating their practice because 10 years ago, it wasn't like that.
Exactly.
Yeah, thank you very much for giving the presentation tonight. Just one final question regarding use of balanced fluid when giving boluses quickly over the likes of 15 minutes. Is that ever used? I know in a lot of different hospitals it's banned due to the potassium level and the risk of causing arrhythmias.
I used it because it only has 4 milligram in 1 liter. So it's not like huge effect. Our extra, how much volume we have in the blood, 5-6 liters. So the 1 liter 4 milliequivalent does not cause hyperkalemia, actually dilute, because only 20% of the volume stays in the blood. The rest goes out. So 20% of the 4 milliequivalent is nothing. It's like 1 milliequivalent in giving, when you give 1 liter, it stays in the blood. So I don't think so hyperkalemia is the issue. Such as I have a patient, you cannot believe it, I gave 3 liters of LR bolus now. This patient is hypotensive, and I give 3 liters. The other one, we use that 30 cc per kilo ideal body weight. It has to be ideal body weight, not the actual body weight. So we give regardless. Sometimes, a patient has CHF with EF 10%, or a patient missed 3 dialysis, last 3 dialysis. I'm really concerned. I should not give 30 cc per kilo ideal body weight. Give it. First 30 cc, you give it. The later one, there is now the talk about, the Clover trial or classic trial, the conservative versus, liberal. There's not much difference. But first 30 cc per kilo, you just give it, regardless of the patient's, the heart condition or kidney condition. But in terms of hyperkalemia, LR, I don't have any problems. I gave it, boluses, no issues with the potassium. Even I'll tell you that the patient I have, heart potassium went down to 2.6, okay? So when I got it from the ED, I gave 3 liters of LR bolus, 3 liters, because patient's bone dry from DKA. The potassium went up from 2.6 to 3.1 after 3 liters of LR bolus. So it does not cause hyperkalemia now.
And it should not, actually, because the level of potassium in it is around 4, and it will certainly bring the hyperkalemia down. But if you compare with normal saline will bring it down more. So it doesn't cause hyperkalemia. It will bring the potassium level down, but not to the same level as normal saline. Is it a reason for me not to use it? No. Would I be afraid of hyperkalemia worsening? No.
Good, thank you. Hopefully our guidance in the UK will change in accordance with using some of the research. Thank you so much again for your experience and your expertise in giving the lecture, and for the panelists as well, to Dr. Kerala for joining in. I just want to invite everyone who's part of the webinar to our next session. Our next session is going to be on June 6th at 9 p.m, which is in RIA time. And it's going to be about the congestion cascade and harnessing the use of Doppler in the ICU. And it's going to be given by Dr. Murad Zanussi, a renowned speaker from Baylor Medical College in Houston, Texas. And finally, I just want to thank you all for joining tonight, for being a part of ICU Reach. It wouldn't be the same without everyone joining, and we are so glad to see the participants every week. We really hope that the service that we can provide is benefiting you and your learning experience. And if you want to help support us in what we do, and you're not a member yet, we would just really encourage you to go on our website, which is www.icureach.com. And on there, you can visit the member section of the website and you can support us in any way that you can. We would really appreciate that. And on the website, you'll also find more the blog that we upload, and also you'll find other resources which will be a benefit to you. The session has also been broadcasted live on ICU Reach YouTube channel, and it has been recorded. So if you want to go back, if you want to share it with other people, or you think people that you work with would find it beneficial, you can find it there. And it will also be uploaded to our website, so please share with others. Finally, I just want to thank everyone, and I think that's everything from us tonight. And I think there's an evaluation form online that we would appreciate if you could